out there would love to, and control for what you can control in a study environment, and acknowledge all those other factors that sit around us that might be influencing the outcomes that we see in this study. In terms of methodology, there were 3 cross-sectional retrospective studies that looked at the relationship between primary care physicians, practices, and implementation of the medical home, used regression analysis for all 3 questions. The study population I limited to our adult members aged 18 to 64, gives us about 230,000 attributed members to all primary care physicians within our network. Looked at adults for a couple of reasons. One, we don't have at that time in 2015, did not have a significant number of pediatric practices in our medical home program, and the measures are just so different and the outcomes are so different. Did not want to confuse the study by those factors. And then of course looked at the primary care physicians and practices. In addition to all what you would expect data points, the member level data, the physician level data, and the practice level data, I introduced this 3M value index score, which I referenced already as an indicator of high quality primary care practice patterns at the physician level. This is a physician level evaluation that I analyzed at the medical home versus non-medical home level. And then there are 6 domains and a composite score, which I'll describe further. So the first question, my committee was very kind to me and gave me a pass on a very simple, just descriptive study to just understand really the basic characteristics of those practices that are participating in the commercially sponsored medical home program versus those that are not. Key differences being that medical homes are larger. None of this is probably earth-shattering to anyone listening on this call. We have an average of 5 physicians in our medical home practices compared to just 2.4 in our non-medical home practices. One of the things that was really striking, if anyone ever really wanted to read 125 pages behind this, is how many solo practitioners there were in our medical home, non-medical home cohort. There was, however, one solo practitioner who is one of our medical home practices, or was at that time. Medical homes, not surprisingly, were much more urban. 77% of the practices in the medical home cohort were in that 5-county metro area compared to just 52% of the non-medical home practices, and have substantially more of our members attributed to them. So 240 members per physician in medical home practices compared to just 91. So clearly they were probably paying more attention than those who had fewer of our members represented in their practices. So this, again, that was sort of my easy context setting question for the overall study. The second question I get into really looks at whether or not medical home implementation seems to have any influence on physician practice patterns. Again, using this value index score, the VIS score from 3M. And what you see on the slide is just a table describing those measures. So down the left-hand side, you see the domains listed: primary and secondary prevention, tertiary prevention, try and attempt to measure health status change over time with the patient mix, continuity of care. I think a really interesting measure that really attempts to look at what the ongoing engagement is between the patient and the provider. They put the emphasis on the attributed provider in this case, but they also look at qualified providers that would make sense for that patient to be seeing based on, again, all claims-based, so just looking at the diagnosis that we see in the claims. Chronic and follow-up care, and then efficiency, they look primarily at the use of pharmaceuticals and ancillary services. So you can see the measures, the metrics, the things that are used in that domain. So this is just a really high-level summary of what I found in that question. And these box plots, the medical home is shown on the right, the non-medical home on the left. This is, again, is a physician level measure, and I didn't attempt to really look at it at a practice level. I really just looked at it at a category level. So compared all of the medical home physicians to all of the non-medical home physicians. And when you look at the medical homes on the right, you do see certainly less variation, and you tend to see higher scores. And in fact, the composite score, the primary and secondary prevention score, the tertiary prevention score, and the chronic and follow-up care scores were indeed higher to a statistically significant degree than the non-medical home physicians. What's interesting to me in this study is that, in this particular question, is that the two domains in which the non-medical home physicians outperformed the medical home physicians, not to a statistically significant degree, but to a noticeable difference, is the population health status change and the continuity score. You know, my thinking, my hypothesis around that is that the fact that so many of the non-medical home physicians are rural has some influence on that, both in terms of, certainly in terms of the continuity score, because there are fewer alternatives to the primary care physician in that setting, but also the population health status change, which measures patients' health status change over time, might speak to the importance of that continuity with that attributed provider. Certainly something of interest, maybe to ponder further, and researchers always love to find something else to research, so interest there. So the final question that I looked at really was focused on medical home ownership, and did what medical home ownership influence total cost of care or utilization rates for high cost services. So took the medical home practices, eliminated those that were very small with less than 250 attributed members, which gave us 107 medical home practices. And when I looked at them across the board, regardless of ownership, they were very similar in most ways. Because we eliminated those smaller practices, we saw even a stronger payer influence, more than 310 members per physician, Blue KC attributed members per physician in those medical home practices. They were all both physician-owned and system-owned, all around 5 physicians per practice on average. The one notable difference is that the physician-owned practices were almost exclusively urban, and that the rural practices that we saw were primarily those that were system-owned. And we did, in fact, see a difference in the total cost of care. And based on our 2015 data, $20, and these are all risk-adjusted, $20 per member per month less in total cost of care per member per month for our physician-owned practices than the hospital and system home practices. I think this is really significant, especially when you think about this in the context of we're comparing high-performing primary care practices to other high-performing primary care practices, because on par, across the board, our medical home practices are generally outperforming our non-medical home practices to the degree anywhere from maybe $9 to $15 per member per month. So in terms of the hospital admission rates and ED visit rates, which is certainly a contributing factor to that total cost of care, was able to look at it based on the actual utilization compared to an expected rate of utilization based on the health status or risk status of the attributed population. So while the physician-owned practices outperformed the hospital-owned practices in this measure to a statistically significant degree, it's interesting to note that the hospital practices were essentially admitting at or near the expected rate for their attributed population, while the physician-owned practices were admitting at a lower than expected rate for their attributed population. Neither the physician-owned practices or the hospital or system-owned practices were having great success in terms of managing ED visits. So certainly some opportunity there. But interesting findings, I think, particularly in that question, and that's certainly consistent with a lot of other studies and evidence that we've seen in this regard. So just a quick high-level summary of the 3 questions, and then a little bit of discussion, and then would love to open it up for discussion with the broader group. Larger urban practices with a strong payer influence are more likely to participate in that payer's medical home program. Physicians in medical homes do appear to demonstrate higher primary care quality service delivery overall, as measured using these VIS scores. and hospital or system ownership. I don't know how to move that little box, I apologize. Associated with higher cost and higher than expected hospital or higher hospital admissions compared to non-physician-owned medical home practices. So, of course, it's a study and there are limitations that are of note. That is, it's a natural experiment, so there's certainly bias in these data. It's administrative claims data. There are likely errors in the data itself. I think more importantly, from a research and what does this mean to us perspective, there, looked at this at the category level, did not attempt to understand what medical home mechanisms were in place, either within the medical home cohort or, more importantly, the non-medical home cohort, because we know that those practices are not standing still. They are just practices that have not chosen to participate in our medical home program at Blue KC. Likewise, fairly limited understanding of their specific practice environment, what might be influencing their practice in terms of physician leadership, the availability of community resources or other factors. And of course, this is just telling us what is interesting, I think, about the Blue KC situation. In terms of implications for building a strong primary care foundation, which I firmly believe is really what the medical home is about. It's not an endpoint, it's a means to an end. There's certainly opportunities to engage small rural practices. Our folks, many of you know, Noel, King Whitlow, Kiana Thompson, very much hard at work in those efforts today. I think really for us as payers, this is no great aha to this group either, but really understanding our influence and quantifying that and looking at that from a provider's point of view helps to put what influence we have, or more importantly, do not have in context. One of the things that I talk about a lot in the paper, I'm not getting into too much in this discussion, although there's one other point I'll make before I close about the role that patients play. When I looked at the descriptives up front on just the distribution of members and some of the findings around the continuity score and other factors, you start to wonder what the rural context and the availability of other resources or access to other services might be playing, and how those patients might be engaging in those other services. But also just simple things like age and gender really do seem to play a role, and perhaps the older female patients are in fact more compliant than others. And there seem to be some hints of that when I drilled into some of the data that I looked at. And then I think, we really all have to really understand how context influences outcomes. There's so much, only so much that you can glean from the numbers. And I think it's so important to consider that. Preaching to the choir, multi-payer collaborations, we know are an important opportunity. But I think the second bullet is one that in that context, we don't talk about very often, and maybe as payers we consider benefit design sort of one of our sort of proprietary competitive advantage domains that we don't talk about. But I do think that when you think about what providers are trying to do, what's the view of the patient on that? And are we really talking actively enough to our members about the importance of primary care? And while, we've, in many markets, ours included, we tried the HMO, you got to pick a primary care physician and, go there first and get your referrals there in a very mandated way that really in the 90s, they told us we don't like that. So we have moved very, very far away from that, and very broad PPO networks with lots of freedom of choice. And, but maybe it's time to talk about, and I know many plans are doing this, do we really want to talk to them about choosing their primary care physician when they enroll, or just expressing a preference for their primary care physician? Tell us who it is. And if you don't have one, maybe we can help you find one. And then certainly managing the cost around those service. Many plans, again, doing that, but I think it's an important piece for us all to be talking about. And then, of course, the importance of building on these primary care foundations to broader accountable care agreements that really do engage the specialists and the hospital systems differently. And of course, no researcher worth their salt, even if I'm not in a research position today, would close their research without talking about the other research that might be of interest. again, patient information. But I think that if I were in a full-time research position today, I would certainly be looking at the qualitative complement to some of these data that we are learning about to really understand what's happening from a hospital and health system point of view. You know, one of those things that I think we have to all think about in terms of context is, even though I looked at the broad categories of hospital and health system ownership versus physician ownership, there's still a lot of variation within that hospital and health system ownership category, how they're compensating physicians, how they're supporting primary care, how they're rewarding primary care within those system environments is certainly something that we won't understand unless we actually talk to people and collect that information. So those are my next steps as a researcher. Our next step is to, mine is to say thank you, but also to ask for any questions that you might have.
Karen, thank you so much. This is Lisa for a fabulous presentation on really important work. And I think asking a lot of the questions that really undergird all the participating organizations' quest for improving quality and keeping track of the impacts of this set of initiatives. I have unmuted all the phones now, so if people have questions, feel free to speak up. There also is a chat function that you can find if you are logged into the webinar. If you prefer to type in a question and I can read it, that would be fine as well.
Hi, Lisa. This is Stephen Peskin from Horizon. How are you?
Good, Stephen. Welcome.
Great presentation. Thank you. Two questions. One, so when you said the expected rate of utilization, that was based on Milliman or based on Kansas City's own actuarial projections? So that was question one. And question two is, I think you said $15 to $20 improvement in the independent versus the system-owned PCMHs, and you mentioned variation even within that. But was that was mostly driven by the reduction in inpatient utilization? Is that right?
Yeah, so with regard to the last question on cost, yes, it appears that the majority of that impact on the $20 differential between hospital-owned physicians and and physician-owned practices is really the difference in hospital utilization. There's probably some pricing differences in there as well, as we all know, but I would say the primary driver of that is the inpatient admission rates. With regard to your first question about how did we set that expected rate, at the time of back in 2015, Blue Casey was working with TRAO, many of you know, then acquired by 3M, and we were using a 3M methodology to set that expected and working with TRAO's consulting group.
Thank you.
Sure.
So, hi, go ahead.
Oh, hi, this is Vince Speenberg, Capital District Physicians Health Plan in Albany, New York. Thank you, Karen, for a good presentation, great presentation, actually, and congratulations on your dissertation. I just had a question. I know you mentioned one of the findings was the non-PCMH practices had outperformed the PCMH practices in the two areas of health status change and continuity score. And then you later on referred to the hospital and system owned practices primarily in the rural sites were hospital and system owned. Do you think that that had an impact on those scores? Because I think you alluded to the fact that the non-PCMH practices were mostly rural.
Yes.
So from a continuity score and health status change, those are kind of correlated and impact one another. Do you think like having a hospital and system owned and those that were primarily rural led to the fact that they may have greater continuity? Yeah,
so I would say that yes, I would agree with what you're stating with regard to the rural context. However, I think that the hospital and health system ownership distinction I was making from a rural perspective is simply that when I look at our medical home practices, virtually almost all of the physician-owned practices are rural, or excuse me, I'm sorry, I misspoke there, are urban. The only medical home practices we see in the I'm following along, Vince. I'm a little slow. In a rural setting or hospital and health system home, could very well be that what we're seeing is really strong non-medical home performance from those physician-owned practices in the rural setting. I think there may be something there. I don't know.
Okay.
I didn't go that far to look at it more closely.
Okay, and then maybe just a side question, or kind of ancillary to the primary focus of your study. Did you gain any knowledge of why maybe some small practices were not adopting the PCMH recognition? Just curious. I know it wasn't the focus of the study. But.
Yeah, no, that would be a great qualitative follow-up to this, is to go out and actually talk to those practices and ask about their, view of PCMH, their view of Blue KC, their view of participation in a commercially insurance, a commercial carrier's medical home program, and the value of that from their perspective. But no, I didn't really go there.
Okay. And will you do you, from your research, do you still see this as a valuable designation and recognition among the practice for a payer to have their provider network in this have this recognition designation?
So in fact, Blue KC has moved to a position where we do no longer require NCQA medical home a PCMH recognition as a ticket for entry into the program. And so I think, I think I sort of alluded at the beginning, and this is me speaking, Karen, not Blue KC, but,
Sure.
I think most of us around the table would agree that the medical home is not the end point. It is the means to an end, and that end would be a stronger, higher performing primary care foundation for all of healthcare, not just for selected practices. And so with that in mind, I think, and with also the understanding that in a programmatic way, we work really closely with our practices. Our team does a great job of getting out there and understanding what they are and are not implementing. That is really synonymous with being a medical home. And so we are probably in a better position to judge and do a review of their practice environment to say, is this in keeping with what we would expect a medical home to do, to demonstrate in terms of mechanisms in place. And so we are making that evaluation today.
Okay, thanks, Karen.
Sure.
Karen, a question came in on the chat, which was, was there a difference seen across all business lines? And then a follow-up question, whether you evaluated Medicare Advantage and commercial entities separately.
So there are no Medicare Advantage lives in this study, so that was not included, and did not. I'm sorry, what was the other part of the question, Lisa?
So if you saw a difference across the business lines?
Oh, yes. Yeah, so I did not look at, that was not one of the factors that I looked at, was whether these were small group, large group, fully insured, or self-funded members. One thing I will say, though, is that the 230,000 lives are all commercial lines of business. And it does include our ASO and minimum premium. So our non-fully insured customers are included in this mix as well. So it's a pretty broad brush, but that would, again, love, what's the next step to look at? Something around that sort of context might be interesting.
So Karen, this is Dick Schunk. I was going to answer the question on the chat, but one thing I'm very interested in is whether or not these is the difference between payer type and also business aspects. So yeah, I love the presentation. I'd love to see more, tease that out more.
Sure.
I know we're dealing with a lot of fully insured employers who have not yet bought in wholeheartedly to this idea. And I think that maybe having that data might be one thing that could convince them to join in.
Sure, absolutely. Yeah, and a good thing to look at, and naively or boldly, I'm not sure which it was, but Blue KC really didn't ask the employers much about whether or not they really wanted in. We just put them in and told them why. And we have with it's not always been easy, but they are all still with us. So have had some really good success in that regard.
Well, I'd love to take some of that and sprinkle it in my market. So.
Would be happy to visit with you. Good to talk to you, Dick.
Any other questions or comments for Karen? Karen, this is Lisa. I wanted to just pose a question that's a little bit more technical, but in terms of working with your claims internally, and I know you have a strong team at Blue Cross Blue Shield KC. A lot of our colleagues are with smaller organizations that don't have the same sort of internal resources. Do you have any words of wisdom in terms of things that you think are really essential if a smaller organization wanted to take something on like this, to ask the same questions that you did?
Yeah, my first go-to would be look to your local academics as collaborators on these kinds of projects. I think they would welcome it, and I think that they would bring a lot of new ways of thinking and a lot of depth to the thinking that we tend to we do flybys a lot with our questions and answers in a business environment where we're all moving at a very fast-paced rate. So I think I would certainly get into the literature yourself to the extent that you can, but look to your academics locally as collaborators, locally or otherwise.
Great, thank you.
And I do think, to Dick's point about the employer market, I do think the more credible evaluations we do of our programs, whether it's this or any other program as payers, the more, voice it gives to that with our customers or others that we, need to influence around these programs.
Just one follow-up, Karen, and this is Dick Schonk again. What would there be? I don't know that I caught it, and you probably said it, but was this population identical with your CPC plus population, or not CPC plus, but your CPC initial population?
Well, okay, so we weren't in CPC, so it was CPC plus, and the physician base is our medical. So from a provider perspective, probably of the 125 medical homes that are included in this study, and I don't know if I have any Blue KC folks on the phone like Noel, but the majority of those, yes, it may not be identical, but it is a very, very, very strong overlap with our CPC plus population.
Okay, so these people were in a PCMH payment approach that you guys were doing, and then they applied to CPC plus after this. Is that
yes?
Correct?
Yes.
Okay.
Yes, and this program, I didn't really speak a lot about this program, but 2015, the program had been in place as a full-fledged program for 3 years, but it was 5 to 6 years out from the first pilot of the Blue KC Medical Home Program in 2015.
Helpful, thank you.
Lisa?
Yeah, hi, Eric, go ahead.
Hi, thanks. Karen, one last question. And again, just as others have said, fantastic presentation. One thing that you might, in round 2.0, you might want to look into in terms of the total cost of care. You did reference pricing differences, which I do think might be interesting to look at. You may also want to look at the relationship between the system-owned and physician-owned practices in terms of how much of the cost may have been driven from the delivery of care being at higher cost settings. One thing we've seen on occasion is where health system-owned practices refer patients to facilities to get tests and have other things done that actually can be done in a primary care setting, but either for financial reasons or because of the way the system's set up or others, sometimes patients will go and have, MRIs or CT scans or have other tests done at the hospital when they could have been done in a primary care office. So that may also be another contributing factor to the higher costs for the health system, as well as the likely increase in the inpatient admissions.
Yes, absolutely. Agree. And just, I guess maybe stay tuned. We are in the process of doing a longitudinal differences evaluation of our program as well. So if we learn anything interesting there, happy to share that as well.
So Karen, this is Dick Shunk again. I just couldn't help it, but when you were talking about, because I remember the days of the gatekeeper and how miserably that failed in the payer side of the thing, I'm advocating in my market that we we resurrect primary care as the gateway instead of the gatekeeper, and make it
absolutely
that you go through your primary care doctor. So I think we need to just change the mindset of people that this is a gateway, not a gatekeeper that you're going to.
Fully agree. It's the kinder, gentler approach.
Yes, right.
Yeah, just to that end, we're doing some things in New Jersey at Horizon to reach out to the, as Dr. Grundy would say, the medically homeless, and inviting them and giving some motivation using some behavioral science to get people, quote unquote, contact attributed in their geography, working with certain of our clinical partners to do that in a HIPAA compliant way.
I like that. Maybe that's a future webinar, Lisa.
I think it is. Any other questions or comments? We have quite a few folks on the line from about, I think, 10 different CPC Plus regions. Anything people would like to share or ask of Karen? Well, with that, thank you once again for everyone for being on the line today, and great thanks to Karen, and congratulations for doing just a fabulous job on this presentation and really reflecting the great work on your dissertation. So congratulations. I have one announcement before people sign off. The Learning in Action Network is having its annual summit in Washington, D.C. on October 22nd. The CPC Plus team has sent out trying to get a sense of whether payers who will be attending that would be interested in attending an informal meeting with CPC Plus team leadership, and to have the opportunity to share your insights and suggestions as some of the upcoming modifications to the CPC Plus are in development. This is not an opportunity to exactly what track 3 will look like. It's more really trying to elicit some sense of what the payers and facilitators and conveners have to offer in terms of insights into how implementation has gone thus far and what they think would be important ideas to put forth. So please contact either your local CMS regional representative or directly to Allison Shippey or Reva Virginkar at the CPC Plus Baltimore office. Let them know if you're interested in attending something like that, if you happen to be going to the Learning in Action Network Summit in October. Thanks everybody for signing in today and listening. Next month we have a webinar with Craig Jones talking about data aggregation, analytics, and reporting. He, as you know, has been assessing various regions around the country in terms of their readiness and capacity, and has a lot of interesting information to share. So that will be a month from today. You'll be getting more notification about that in the next couple of weeks. This has been recorded, so you'll be able to share this recording with other people in your teams or in your regions if they were unable to attend today. And Karen has very generously shared her slides with us as well. So thanks a lot, everybody. Have a good rest of your day today, and we'll be talking soon.
Thank you, Lisa.
Thanks, Lisa. Bye.